Hi friends, continuing with the part 2 of the MCQ. So we try to cover in this part 2. So starting with the question, the first again the same old question, 6 hours assault, what will be the wound management? It's a basically old question. Nowadays our aim should be primary closure whenever possible. So debridement with the primary closure will be the answer. And even in the case of the open fractures, earlier it was said that within 6 hours it has to be managed. Nowadays it is being said that debridement has to be done first, debridement and irrigation, and within 24 hours the wound should be managed. Now coming to the second, adult soldier with the bilateral inguinal swelling with positive cuff impulse, what is the most appropriate? So it's talking about bilateral inguinal hernia. Whenever there is a bilateral inguinal hernia or a recurrence of inguinal hernia, laparoscopy has an advantage that with one laparoscopic go, we can manage both sides of hernia. So the answer will be laparoscopic hernia. Elderly female that has back and she is stooping and bending her back while she walks to relieve the pain. What is the diagnosis? So here basically we are talking about two types of pain. One is like a true colidical pain, colidication pain, and the other is like the pain rising because of the lumbar spinal stenosis. If the patient has claudication pain, the characteristic of the claudication pain will be the patient would start normally and after some time the patient would have pain. And this pain would disappear once the patient takes rest. While in a case of lumbar spinal stenosis, when the patient stoops, he has a relief of pain. So a very important point, when the patient stoops, he has relief of pain that goes in the favor of lumbar spinal stenosis. Something years ago, patient will come with a history of midline neck swelling, moves up and down with tongue protrusion. What is the diagnosis? So straight answer is thyroglossal cyst. Now the important thing is for the what is the management of thyroglossal cyst? The management of thyroglossal cyst is surgery, and the surgery is cyst trunk procedure, which involves removal of even a hyoid part of the subhyoid bone. And what is the most common location of the thyroglossal cyst? It is the subhyoid region. Patient is toxic, temperature is high, WBC high, bilirubin high. Ultrasound shows cystic lesion without septation. CT scan homogeneous, not sure. Thick wall with peripheral enhancement. What is the most appropriate management? Now here, there are two types of liver abscess we would come across, and there would be confusion. One is pyogenic liver abscess and the other is the amoebic liver abscess. And what is the difference? In the amoebic liver abscess usually occurs in the young patient who has traveled to an area where the socioeconomic condition is not good and hygiene is not proper. So the patient will have a history of travel, is usually a young patient, and the patient will present with right side right upper abdominal pain, maybe mild fever, maybe mild jaundice, etc. This is amoebic liver abscess, while a pyogenic liver abscess usually occurs in the old patient and has a focus of infection. So like patient may give a history of appendicitis, patient may give a history of cholangitis. Right now, the cholangitis is the most common cause of the pyogenic liver abscess. That is so we will have a focus of infection, and the patient will have high fever with chills, etc. How to differentiate? In the radiology, one characteristic feature in the pyogenic abscess will be enhancement of the CT scan. So peripheral enhancement of the CT scan is characteristic of pyogenic liver abscess. And what is the management? In the amoebic liver abscess, the usual management is just metronidazole in double dose. That is, most of the abscess will resolve. Sometimes when the abscess is huge and there is a risk of rupture either into the peritoneal cavity or into the pleura, in those cases their option is aspiration, percutaneous aspiration. While in pyogenic abscess, the management is percutaneous tube drainage has to be done. Percutaneous continuous tube drainage till the pus is out, plus IV antibiotics is the treatment of choice. Here the patient is having peripheral enhancement, so I would go for pyogenic liver abscess. Now what is the cause of this pyogenic liver abscess? This pyogenic liver abscess is maybe because of this, as I said, most common cause is like cholangitis. So we have to take care of the abscess, one, plus we have to take care of the CBD obstruction. So maybe we have to go for, if the choices are for the management of the abscess, so the answer will be percutaneous tube drainage, plus we have to go for a stenting of the common bile duct. Next, young patient underwent open appendectomy or stayed in hospital and came back on 8th day. So patient is having on the 8th day with surgical site pain on examination. Abdomen was soft and lax, tender in opposite side with redness. So the patient is having tenderness on the opposite side. So we are suspecting surgical site infection which is deep. There are two types of surgical site infection, superficial and deep. Superficial, we have to just manage the wound, but the deep surgical site infection, we have to look for collection where it is occurring. So maybe we can go for a CT scan and then we can go for CT guided drainage. Patient came with fracture and compartment syndrome. What is the first alarming sign? Okay, the compartment syndrome, the what is the reason of the compartment syndrome? The reason of the compartment syndrome can be because of the fracture, it can be by the snake bite, it can be because of the reperfusion injury, it can be because of the arterial injury, etc. When we say compartment syndrome is high, a figure of 30 mmHg is said to be like high compartment syndrome. And why we need to treat compartment syndrome? Because the high risk of loss of the limb. The first symptom is usually severe pain, even in the stretching of the, even in the passive stretching of the muscles. This is the first symptom, and a bit late symptoms will be like paresthesia. We may notice paresthesia. Okay, so among the choices, paresthesia will be occurring earlier, while absent pulse and toe discoloration usually comes in the late part. And what is the treatment? Treatment is 4-compartment fasciotomy. Traumatic patient presented to ER with profusing bleeding from the nose and mouth, cyanosed, with decreased breath sounds on the right side of the chest, mostly was unstable. Which of the following is the most appropriate next step? Now here, as per the ABCD, first we have to take care of the airway. The patient is having profuse bleeding from the nose and mouth. So if somebody is having profuse bleeding from the mouth and nose with cyanosis, this is an indication of intubation. So first of all, we have to take care of the airway. So we have to intubate the patient. After intubation, we have to look for breathing, that is breath sides sounds are absent or we have to do chest tube thoracostomy. But the first step will be airway, not the chest tube. Charcot triad is specific for which disease? Charcot triad, that is the pain, jaundice and the fever, which is specific for cholangitis, but unfortunately this is present only in 10% of the patients classically. So Charcot's triad is specific for cholangitis. Next, 25-year-old lady presents with a hard, mobile, well circumcised, painless left breast mass that has been increasing in size from the past few months and was not related to her menstrual cycle. Okay, so the patient is young. The most important thing, the patient is a young lady and she has a well circumcised painless left breast mass which is moving. So this is mostly going, and it is increasing in size. So this is going with the fibroadenoma because the patient is young. Now there can be one confusion can be maybe some may suggest for phylloid tumor, but phylloid tumor is usually occurring in older age group, not in the younger age group. So it will be like in 40s and 50s. And phylloid tumors are usually very huge, not like small. While fibroadenomas are giant fibroadenoma, we said when the size is 5 centimeter. As the patient is young, mobile, so I would go for fibroadenoma. Now coming to the next patient, obese, history of jaundice for 1 week with anorexia. Abdominal pain, examination shows right upper quadrant tenderness, no history of medication. This what is an initial step. So the moment somebody is having a history of jaundice, the first thing we have to confirm the diagnosis, that is by going by the blood investigation. If the options are blood investigation, we would go for a liver function test. In the liver function test, we would go for which type of bilirubin is high, bilirubin direct, indirect. So if the bilirubin direct is high, it goes in the favor of obstruction, while indirect bilirubin is high, it goes in the favor of hepatitis. Similar to that, we have to look for the enzymes. SGPT, SGOT is high in the liver disease, liver parenchymal disease like viral hepatitis, while alkaline phosphatase will be high in the obstruction. After we have confirmed the diagnosis by liver function test, then we will go for the radiological investigation. In the radiological investigation, obviously the first thing will be abdominal ultrasound, and in the ultrasound our target is to look for what is the condition of the common bile duct and the gallbladder. Is the common bile duct dilated? Then we have to further investigate further by ERCP or MRCP. Coming to the next, 30-year-old when appendectomy, pain at the side of the wound. Again, this is a superficial site infection, so we have to open wound. Patient with penetrating neck in the zone 1 and is bleeding. What is the best management? Neck is divided into zone 1, zone 2 and zone 3. Zone 1 is thoracic inlet to cricoid cartilage. Cricoid cartilage to angle of mandible is zone 2, and zone 3 is above the angle of mandible. The most easily accessible site is zone 2, and the toughest site is zone 3. So for all the zone 3, we usually don't go for surgery, we go for CT angiography. While for zone 2, and for zone 1 and zone 2, if the patient is actively bleeding, we have to go for surgery, and if the patient is not actively bleeding, is stable, then we should go for CT angiography and further management as per that. And the most easily accessible part is zone 2 injury is the most easily accessible part. Patient post RTA chest X-ray shows 3rd, 4th, 5th and 6th rib fracture with no pneumothorax. What is the next step? Now here the patient question is talking about continuous 3 or 4 bones fracture. It's possible that it may be a bad recall, and the examiner wants to ask about the flail chest. In the flail chest is defined as 3 or more ribs fractured at 2 or more sides. So what happens is there is a segment of flail This segment moves opposite to normal chest movement. That is, on inspiration it goes inward, and on expiration it goes outward. And what is the management of such a condition? The management of such condition is, the first thing is the analgesia, proper analgesia. If the patient is okay maintaining oxygen saturation, nothing to be done. But if the patient is not maintaining oxygen saturation, then in those cases intubation has to be done. Next, patient post-surgery developed left limb edema up to the thigh. Which anticoagulation to be given? So it's talking about the deep venous thrombosis. And right now, the recommendation for the treatment of deep venous thrombosis is low molecular heparin weight should be started. And soon we have to add the warfarin, and warfarin is to be continued for at least 3 to 6 months. Next is 40-year-old woman with no pain, but you notice jaundice. She has high direct bilirubin and high ALT. Maybe he's talking about the high alkaline phosphatase. What is your diagnosis? So the patient is having painless jaundice with direct bilirubin high and alkaline phosphatase high. So this goes in favor of, if somebody is having painless progressive obstructive jaundice, it with a palpable gallbladder, as per the Curvaceous law, it goes in the favor of periampullary malignancy, and the most common periampullary malignancy is carcinoma head of the pancreas. Next, patient diagnosed with tubular colon cancer in the sigmoid colon, which was resected completely with a safe margin. What is the next step? Maybe the examiner wants to ask about the tubular adenoma. So if the patient is having a tubular adenoma which has been resected, as we have to just keep the patient in follow-up. But the thing is, this question is incomplete. Usually they will also give us the diameter, because what is the diameter? If it is, what is the size? If it is more than 1 centimeter, again the follow-up period is different. And if it is less than 1 centimeter, the risk of recurrence is very less, or the risk of chances of recurrence is less. But we have to keep the patient in follow-up. Male in 20s has fever, epigastric pain, jaundice, there is epigastric tenderness, abdominal ultrasound shows hypoechoic mass with peripheral enhancement. What is the management? Now, this peripheral enhancement, with the moment we get this peripheral enhancement, this is usually seen in CT scan. So that goes in favor of pyogenic abscess, but it is an ultrasound. So maybe just they have written. So ultrasound, there is a collection. Hypoechoic mass on ultrasound, a young patient. Fever, epigastric pain goes more with favor of amoebic liver abscess, and the treatment is just metronidazole in double dose. Patient has ischemic heart disease, came with sudden severe abdominal pain in the left iliac fossa and tenderness. So the patient is giving a history of ischemic heart disease. Ischemic heart disease is one of the causes of formation of thromboembolism. So here what most likely has happened is, one of the embolus has gone into left side of the colon. So left side of the colon is the most common GI organ to be affected by ischemic colitis, and so this patient is having most likely ischemic colitis. And in the ischemic colitis, most of the time the patient does not need surgery, and most of the time patient just is managed conservatively, and patient usually presents with pain, bloody diarrhea, maybe fever, but most of the patients are managed conservatively. So this is an example of mesenteric ischemia of the colon. 60-year-old patient with difficulty swallowing, liquid, pain and swelling and regurgitation. What is the most diagnostic test? Now, old patient is having difficulty in swallowing liquid, as well as pain and swelling and regurgitation. So this goes in favor of, if somebody is having more with dysphagia, more with solid and less with liquid, it goes more in favor of malignancy. But if the patient is having more with liquids, more dysphagia with liquids, this goes in favor of motor disease of the esophagus, like eclasia cardia. So first we have to go for barium swallow, and after barium swallow we have to confirm the diagnosis by sphincter manometry before we go for any procedure or any surgery or any intervention. So if somebody is asking about best test, if we go for lower esophageal sphincter manometry. But if somebody asks the next step is barium swallow. So first we go for barium swallow, and then we go for lower esophageal sphincter manometry. A woman with a breast mass for 9 months underwent mammogram and showed a speckled mass with suspicious microcalcification and axillary lymph node involvement. Birate 5. Next step. Now birate 5 is like having high chances of malignancy. So we have to go for a core biopsy. We have to go for a core biopsy. In grade birate 4 and birate 5, we have to go for a proper biopsy, because these are suspicious and highly suspicious. You attended the surgery theatre, and okay, not a good question. That you have to just inform the surgeon that you are doing the wrong surgery. Adult fell from height, complains of severe heel pain. He is conscious, oriented, and has stable vital. What is the next step? So somebody having falling from height, we have to keep in mind the patient can have fracture of the heel. At the same time, patient can have a lumbar vertebral fracture. We have to keep in mind lumbar vertebral fracture. And if somebody is falling from the height, we have to also keep in mind there is a chance of aortic rupture in such patients. So we have to keep a watch on these things. So, okay, so I would maybe I would go for like pulse palpation. Okay. Elderly patient came with severe headache to ER, then suddenly deteriorated and decreased level of consciousness. CT done, hematoma best management. Any patient of hematoma, if he is deteriorating, we have to go for evacuation. And specifically more like in epidural hematoma, the patient comes with lucid interval. That is, patient is okay, and suddenly patient deteriorates. We have to go for an urgent surgery. Patient sustained a chest stab wound injury and examination. There was stony dullness over the right side. Stony dullness over the chest means there is fluid collection. So there is a history of trauma and there is a stony dullness. So it is a hemothorax. Next, 28-year-old patient medically free presented to ER with history of abdominal pain, nausea, anorexia, and lower quadrant pain, diverticulitis with 20 ml fluid, 2 into 2 centimeter. Okay, so this is basically talking about the diverticulitis, and it is having a small collection. So diverticulitis may be complicated, may be uncomplicated. Most of the times, diverticulitis is uncomplicated. That is, the patient presents with pain. Pain is starting from the umbilical region, going to the left lower abdomen. Pain in the left side, vomiting, nausea, fever, and that is managed most of the time conservatively. If the patient develops complication in the form of an abscess, perforation, then we have to do something. Now there is something known as Hinch's classification for the complicated diverticulitis. In the grade 1, it is like a small abscess, very small abscess. Grade 2 is large walled off pelvic abscess. Now in the grade 1, we can manage the patient conservatively, like if the abscess size is less than 4 centimeter, we can just manage by IV antibiotics. While in grade 2, large walled off pelvic abscess, we have to go for a percutaneous tube drainage. And in grade 3, which is purulent peritonitis, and grade 4 is fecal peritonitis, these require urgent surgery. So this is most likely a small 4 centimeter 2 into 2 centimeter abscess cavity. We will go for conservative IV antibiotics only. And bowel rest. 30-year-old man underwent appendectomy, complaining of pain of the site. Again, open superficial surgical site infection. Next, patient had central abdominal stab wound. He is vitally stable. What is next? In a case of gunshot injury, laparotomy is mandatory, while in a case of stab wound, we have to first see whether the peritoneum is breached or not. That can be seen by wound exploration. So wound exploration can be done, and if the patient has breached, if the patient does not have any breach of peritoneum, we can manage the patient without surgery. But if the patient has breach of the peritoneum, now again there are two possibilities: patient is stable or unstable. So we have to make a watch. We have to watch the patient for at least 24 hours. If the patient has a breach of peritoneum, plus if the patient develops peritonitis, instability, features of bleeding, patient deteriorating, then we have to go for surgery. Otherwise, just wait and watch. Patient with abdominal pain, vitally stable imaging show increased thickness of the sigmoid and thumb printing sign due to edema. Due to edema, what is the next? This is again most likely ischemic colitis of the ischemic colitis, and the most common site of the ischemic colitis is the sigmoid, colon, and splenic flexure region. So this colonoscopy will be able to confirm the diagnosis. Thumb printing sign is usually associated with ischemia, but it may also be found in other situations. But thumb printing sign is usually associated with ischemic colitis, ischemia. Trauma patient currently well lucid interval. So lucid interval, if you find lucid interval, it means epidural hematoma or extradural hematoma, and it needs emergency surgery. Spleen injury in a child, but hemoglobin is low. What to do? Spleen injury management is, if the patient is stable, we have to manage him conservatively, irrespective of the grade. And more so, especially in a child, we want to conserve the spleen in adults also, but more in child, because the chances of opportunistic post-splenectomy infection is more in a child. So that is why we should try to conserve the spleen as much as possible. But if the patient deteriorates, if the patient is unstable, we have to go for surgery. So it's post RTA patient had lower back pain, unable to move, management done while waiting for the, okay, we have to stabilize the back. That's very important part of the trauma management. Patient with symptom sign of bowel obstruction on the way to, he has an upper GI bleeding. Okay, this is a stupid type question. Intestinal obstruction patient, maybe he's asking about like Malleus tear. Sometimes the patient has intestinal obstruction, has repeated vomiting, and because of that Malleus tear occurs. But most of the patient will be managed conservatively, and the diagnosis of the bleeding, what type of bleeding, from where the blood has occurred, will be by endoscopy. But not a good question. Next, male patient in 20s presented with severe epigastric pain. Starts suddenly on examination. There is a diffuse tenderness, diffuse slight blood, sluggish bowel sound, amylase. Which of the following is the Those most likely the patient is having acute bowel perforation. Okay, so we have to do a chest X-ray in an erect position to find gas under diaphragm. Patient of stab wound, uh, penetrating injury with omentum coming out. Any patient who is having like a stab wound and where omentum is coming out, we have to go for a laparotomy. We cannot just deposit back the omentum like this. We have to do a proper laparotomy. Patient with abdominal pain, vitally stable, imaging shows increased tegmental segment, thumb printing sign. Okay, that is going ischemic colitis. Diagnosis may be confirmed by colonoscopy. Colonoscopy helps us in making the diagnosis of whether it is a full thickness ischemia or partial thickness ischemia. Partial thickness ischemia usually managed conservatively, while full thickness ischemia usually leads to gangrene or bowel perforation and may need surgery. Anterior duodenal perforation, what is the management? Okay, so when there is a duodenal perforation peritonitis, it is being managed by omental patch. This is known as Graham's patch. Next scenario by the hydrated cyst. So hydrated cyst management is actually surgery, but before we manage by surgery, first we have to give the drugs. So initially we start with the albendazole and then we plan the patient for surgery. Most common surgery right now which is being used is the pair surgery. We call it pair. That is we have to puncture it's done under we have to puncture the cyst, then we have to instill the puncture and then aspirate all the contents, and then we have to instill the scolicidal agents inside the inside the cyst, and then we have to re-aspirate. This is known as pair technique. But there are other types of surgery also being done, like sometimes we have to remove a part of the liver, sometimes we have to do the surgical deroofing, etc. But we have to do the surgery. Surgery is the main state of the treatment. Case of pelvic surgery, fracture in the pelvis, extraperitoneal bladder injury. Extraperitoneal bladder injury can be managed simply by putting the catheter for around 2 weeks. Patient post-trauma has distended neck vein that does not move with respiration in his cardiac output 2.5. So cardiac output was low, distended neck vein. This goes with the cardiogenic shock. 55-year-old presents with fever, pain in the perineal region. Upon further questioning, he has also complained of frequency, urgency, dysuria, decrease in stream and physical examination. Abdomen is soft, non-distant, non-tender. Digital examination demonstrates severe tenderness. If you find on digital examination severe tenderness in the anterior aspect, this means the prostate is tender. So this goes with the favor of acute prostatitis. Road traffic accident with severe injury to the thoracic vertebra, with paraplegia, breathing complete. Now what is the next? Here most likely the examiner wanted to ask about something associated with thoracic vertebra injury with paraplegia. There is something known as spinal shock. Here in this patient, neurogenic shock, patient goes into shock, and in this is a peculiar type of shock where the patient has low blood pressure as well as bradycardia because there is sympathetic blockade. So the patient presents with low blood pressure and bradycardia. We have to think about the spinal shock. Initially we have to give the IV fluid and later on manage as per the shock. 30-year-old man underwent appendectomy, forceps, again the same superficial surgical site infection. 50-year-old male complaining of right iliac fossa, dull leg, pain. Examination duet had right iliac mass with positive cuff impulse. The examining doctor found a bluish tinge on the mass surface and percussion type was positive. Okay, so here we have to the patient is having a mass which is positive with cuff impulse. So the first thing which comes into our mind is hernia. But what we are finding is the doctor found a bluish tinge. So if we are finding something with a bluish tinge, so it is most likely a varices. This is known as saphina varix, and it is one of the differential diagnoses with femoral hernia. It is usually found below the inguinal ligament, not in the iliac fossa. It is below the inguinal ligament, not in the iliac fossa, as shown in this in this question. So how to differentiate? The main differentiating point is we will also find one, there will be a bluish tinge. The patient will have cuff impulse. The other thing is we will find the features of varicose vein in this patient. So the whole of the veins will be dilated. Then we make the diagnosis of saphina varix. 32-year-old man presents asymptomatic mass in the right testicle. Okay, so if somebody has having a mass in the right testicle, and if you do an ultrasound, you find there is a solid mass in the right testicle, it is cancer unless proved otherwise. But are we supposed to do the biopsy? And the answer is no. So what we have to do is we have to do a high inguinal orchidectomy. So why we don't do a biopsy? Because if we do a biopsy through the scrotal skin, we will spread the cancer to the skin of the scrotum. So that is why biopsy is contraindicated, and we have to do the high inguinal orchidectomy. And this testis specimen is sent to the histopathological examination. And once we know the diagnosis, because then we have to further plan the treatment, because the testicular cancer, the most common testicular cancer is germ cell tumor, and in the germ cell tumor it can be divided into seminoma and non-seminoma. But the treatment options for seminoma and non-seminoma is totally different. Seminoma is highly radiosensitive, while non-seminoma is not highly radiosensitive. So for seminoma, we have to go for high inguinal orchiectomy followed by radiotherapy, while for non-seminoma tumors, we have to go by high inguinal orchiectomy followed by this lymph node dissection in the retroperitoneum and further chemotherapy. Adult soldier with bilateral inguinal hernia, we have to go for laparoscopic repair. Most affected nerve in patent ductus arterial surgery. Okay, left recurrent laryngeal nerve is sometimes injured in patent ductus arterial injury. Okay, patient had RTA and present to the initial was asking about water and then became confused. So this is talking about the level of the shock. There are 4 levels of the shock. But once the patient has crossed heart rate of 140 and the patient is confused and patient is agitated, we have to think about class 4 shock. So we have discussed in the previous lecture. Open book pelvic fracture, what is the best treatment? So any patient having hypovolemia, the first thing is we have to start with the crystalloid, and ringer lactate is one of the best. Traumatic patient presented to ER with profuse bleeding from nose and mouth, cyanosed with decreased breath sounds. Again, the patient is having bleeding from nose and mouth. So nose and mouth bleeding along with cyanosis. This is an indication of intubation. So right chest thoracostomy will not be the first thing. The first thing will be intubation, followed by, after that you have to do the chest tube insertion. 36-year-old patient with a left neck mass. So patient is having a left neck mass 2 into 2 centimeter in posterior angle of mandible. Ultrasound normal thyroid, left large with cystic component. FNAC shows all smears show follicular thyroid. Okay, so here we have to keep in mind any aberrant lateral thyroid tissue, any thyroid tissue found on FNAC in the lateral part of the neck is not normal thyroid. It is a metastatic thyroid cancer coming from the papillary cancer. So aberrant thyroid tissue found in the neck is metastatic thyroid cancer coming from the papillary cancer. Patient had appendiceal mass and discharge home with the next step. Now this is a controversial question. Nowadays it is being said that no need of doing interval appendectomy in all the patients. But yes, if interval appendectomy is done, it has to be done after around 8 to 12 weeks. Patient post appendectomy came post no active complaint. Seroma. So it's talking about the seroma. Seroma is strial fluid collection in the tissue planes. So it's non-infectious, it's not pus, so we don't need to do anything, just regular wound dressing, and if the seroma is huge, we can just aspirate with the needle. Thyroid cancer case had mixed component, solid and cystic. Okay, what best model reach the diagnosis? Whenever we are taking the biopsy, basically in the thyroid, it is not the core biopsy. Usually we go for an FNAC, not the core biopsy. And if we are going to take a FNAC from a mixed, like solid and cystic both, we should always try to take the FNAC from the solid part. So under ultrasound guided, we have to target the solid, because the solid will give us the result. So ultrasound guided FNAC from the solid component. Inferior lateral injury to the knee causing fracture of the head of the fibula. Fracture of the head of the fibula, it is common peroneal nerve injury. Common peroneal nerve is associated with, is around the neck of the fibula. Patient had motorbike accident with mid shaft fracture of the femur. What to do before? So, shaft of the femur fracture, the most important thing we have to keep in mind is patient has lost large amount of blood. So we have to keep in mind about the apart from this analgesia and other things, we have to keep in mind about the shock. Next is 18-year-old male with a stab wound next to the umbilicus with a small opening, clean and bleeding. Is the vital stable with normal lab results. CT scan report showed a small splenic laceration with minimum fluid surrounding it. What is the best? So if now this is not a blunt trauma. This is a lacerated. This is a stab wound, and for the stab wound, the management of the spleen is same as blunt trauma. Like if the grade is less and if it has stopped bleeding, we have to manage the patient conservatively. Otherwise, we have to remove the spleen. So it depends on the grade of the injury and depends on the vitals. Patient had a stab injury in front of right or left ear lobe near or below the angle of mandible. They're oozing of blood. On examination, patient is conscious. What is the next step? Now, this patient, there are 3 levels of injury: zone 1, zone 2, and zone 3. This is zone 3. So zone 3 is not easily accessible by surgery. So we avoid surgery and we go for CT angiogram, and we managed by embolization, because it is very difficult to manage this patient by surgery. Patient underwent a hernia repair operation 12 years ago, now present with signs of intestinal obstruction, which is the following is the most likely cause. Now this is the adhesions. Usually the moment we open an abdomen, the chances of adhesions are there. The adhesions usually form more in the pelvic surgery, but here the chances of adhesions are maximum in first 5 years of the surgery, and even in that first 1 to 2 years, and then the incidence of the adhesive intestinal obstruction decreases, and by 10 years the chances of adhesive intestinal obstruction practically disappears. This is one. Second, this patient has undergone inguinal hernia repair surgery. So it's not written in the question, was it like obstructed hernia? So if the patient was having an obstructed hernia, a strangulated hernia, still there was a chances of adhesion. But if it was just a simple hernia with remesh repair, the chances of adhesions are very negligible. So I won't go for adhesion, I would go for causes relevant to the prior surgery. Next, patient is involved in RTA with isolated injury. He is in coma for 5 days. What is the appropriate to this early management? So if for temporary feeding, nasogastric tube is good for temporary feeding, like for 5 days or for 7 days, nasogastric tube. The others are like gastrostomy tube feeding, is a surgical procedure we avoid for doing for like temporary for feeding. Central line feeding, no, we avoid for short term. So I would go for nasogastric tube. Patient with a stab wound anterior to the neck, he is alert, but in lab oxygen at 82%. What to do? So any stab wound in the neck and the oxygen saturation is less, we have to intubate the patient. We cannot wait and watch, because the hematoma may increase and suddenly the patient may become unconscious because of the decreasing oxygen. So the answer will be endotracheal intubation. Patient after trauma have shortness of breath and decreased air into the left lobe, and the left lung was hyper-resonant to percussion. What is the next step? So this is talking about the pneumothorax. So in the pneumothorax, we have to go put the chest thoracostomy. We have to go for chest tube. Victim of RTA who did undergo ureteroscope, urethrogram, and found injury in the bulbar urethra. For any injury of the urethra, bulbar urethra, suprapubic catheter SPC has to be done. RTA with cervical emphysema, decreased air entry, and pneumomediastinum. Now this may be, if we are finding pneumomediastinum, decreased entry, and cervical emphysema, this may go for tracheobronchial injury. Patient had liver laceration, patient is hemodynamic unstable. Unstable patient, liver laceration, we have to open the abdomen. The first thing is the perihepatic packing. So the packing decrease is the first thing we do. But the problem with the packing is we have to remove the packs after 48 hours. So we do the packing, remove the packs after 48 hours. And also these patients develop decrease in the platelet count. So we have to keep a watch on the platelet. And when we put the pack, there is a chance of infection. So we have to keep a watch on the infection. We have to keep a watch on the platelet count. Platelet count is usually low, so you have to sometimes give the platelet, and you have to remove the packs after 48 hours. Old patient in ICU with acalculous cholecystitis. For acalculous cholecystitis, most of the patients are too sick to go for any surgery like cholecystectomy. So what is best done is we put the percutaneous cholecystostomy tube, and all the dirty bile is being removed. Cholecystostomy tube will be the answer. 12-year-old received a non-specific blunt trauma in his abdomen and later preserved with generalized abdominal pain. Imaging of the spleen showed a 7 mm hematoma, 4 cm tear. Your management. Now, the spleen trauma, we try to manage the patient conservatively. This is one. The second, it depends on not the grade, but it usually depends on the patient's vitals. If the patients are vitally stable, we have to go for conservative management. Child presents after trauma. CT shows minimal abdominal fluid collection and grade 3 splenic injury. Patient is stable. Again, is stable patient, same. Patient found to have anal fistula on 7 o'clock. Most common anal fistula opening is. Now here it is talking about the Goodsall's rule. In the Goodsall's rule, if the patient is having external opening in the posterior, the internal opening will be in the posterior midline. This is Goodsall's rule. Female get high energy accident with silt belt sign on X-ray, chance fracture. What will be associated? The chance fracture. This chance fracture is continuous fracture of the spinous process of the vertebra, and it is associated with seat belt sign. And when there is a seat belt sign visible on the skin of the patient, it means the patient has severe hyperflexion injury. So there is a risk of duodenal perforation. There is a risk of aortic injury. So the answer will be duodenal perforation. Patient is a post-esophageal dilatation, 8 hours, present with chest pain and voice change. So sometimes esophageal dilatation procedure is associated with perforation. Patient with blunt chest injury result in fracture of 3rd, 4th, and 5th rib in more than one side. So it is flail chest because it's at more than one side. So what we have to do, the first thing is analgesia, and if the patient is okay, it's okay. Otherwise, if the patient is having less oxygen saturation, then we have to intubate the patient. Right inguinal hernia repair, now present with shrunken right testicle. Now, so this is one of the complication of the inguinal hernia surgery. Sometimes we tie the testicular artery. So this is not pampiniform plexus, but testicular artery ligation gives rise to ischemia. Next is male patient complains of episode of hematemesis, normal past medical history, lab showed mild anemia, all except elevated urea level in the blood. What is the diagnosis? Episode of hematemesis, normal. So patient is having episode of hematemesis. Okay, then maybe peptic ulcer disease. The question is incomplete, by the way. Patient presents with pain and an itchy mass in anus after defecation, as well as painful defecation with streaks of blood. So a streak of blood with painful defecation goes in the favor of anal fissure. Which type of hernia is above and lateral to the, okay, above and lateral. So this is actually bad recall. Maybe above and medial is inguinal hernia. Okay, below and lateral is femoral hernia. Patient underwent hernia repair with mesh and now complaining of pain. Okay, so we usually manage the patient conservatively by NSAIDs. Case of pancreatitis 5 weeks ago. Now she has epigastric tenderness and cannot tolerate food with vomiting each time. While also you can find large mass, thick wall and fluid inside, which is heterogeneous. Lab 3. What is the diagnosis? So patient is basically having pancreatitis, but it is only 5 weeks. So it is so this is only 5 weeks. So and it is cannot tolerate food with vomiting. So it is basically a fluid collection, acute and thick wall and fluid inside, which is heterogeneous and non-liquefied. 3 for WBCs, but it is infected. But it's an infected. So most likely walled of pancreatic necrosis. Okay. Walled of pancreatic necrosis with infection. Okay. The most common cause of nipple discharge in non-lactating women is the most common cause of nipple discharge in non-lactating is intraductal papilloma, and intraductal papilloma usually arises from the one duct, and usually it is the blood discharge. And what is the management? The management is we have to remove that duct, that is known as microdocotomy surgery. 40-year-old female with a 12 years history of varicosities, complaining of left limb edema and standing distal pulses are intact, and there is bilateral varicose vein. So for varicose vein, if it is very small, less than 3 mm, the management is sclerotherapy. If it is more than 3 mm, then we go for either surgery. But nowadays surgery has been replaced by the procedures which are done by endovenous, either endovenous laser, okay, or endovenous thermal ablation technique. Morbidly obese men with hiatal hernia and GERD, grade 3, what is the best procedure? For obesity surgery, if somebody is having severe GERD, sleeve is contraindication. Sleeve increases the chances of GERD. So the answer will be ruined by gastric bypass. Your finger full of blood, but it was normal. CBC was, what is the investigation? It is a high diagnostic value. Old age patient present with fresh blood per rectum. You did rectal examination and your finger is full of blood, but colonoscopy was normal. Okay, something anorectal colonoscopy. So maybe it's just talking about proctoscopy, not colonoscopy. CB first. So patient is hemoglobin is 8. What is the investigation? It is a high diagnostic value. Okay. Sometimes these patients have, okay, either we can go for a CT angiography or we can go for technetium 99 scan. That will, so technetium 99 scan can be used to diagnose. Patient elderly, from where the blood is coming. Okay. So RBC is tagged. Okay. Patient elderly with central abdominal pain. CT shows a small bowel cancer with calcification. Okay, with calcification, sometimes it is found in the carcinoid. Okay, sometimes even in the gist, which is not given. So, patient with dysuria, cloudy urine with bubbling for 2 months. He has a history of recurrent left iliac fossa open for the last 2 years. Colonoscopy showed no diverticulosis. Cystoscopy dome showed erythema on the dome of the bladder. Oh, so basically, a patient is having a diverticular disease, which is complicated disease with the formation of a fistula between sigmoid colon and the bladder. How do we know that? The patient is passing the air bubbles. That is one. The second thing, on cystoscopy, we are finding there is erythema on the dome of the bladder. So this is basically fistula between the sigmoid and the bladder, which is a complication of diverticular disease. This may also be found in some sorts of cancer. 50-year-old with ischemic heart disease, diabetes mellitus, admitted to ICU with severe pneumonia. Okay, so patient is admitted with pneumonia, treated with antibiotics. Patient, he developed hypotension and treated with hydration, and on admission lab was normal. After 3 days, LFT was abnormal. Total bilirubin is 20. Very high AST and ALT. Okay, shows unremarkable finding. Okay, so this patient is basically having we call it shock liver, uh, shock liver. Okay, or ischemic hepatitis is often used. This is basically because of hypoperfusion. So because of the hypoperfusion, the liver, there is a decreased blood flow to the liver, and the patient presents with is high AST and high ALT. And it is the hepatitis is basically a misnomer because it is not a hepatitis. We call it hepatitis because the lab investigations are same as in hepatitis. So it is basically shock liver or ischemic hepatitis. Healthy patient presenting with dysphagia with no healthy, just a minute please, where were we? I don't know. Where are we? Healthy patient. Okay, we did this. So healthy patient presents with dysphagia with no family history of esophageal. What about the smoke? Strongest risk factor for if somebody is asking you strongest risk factor for esophageal cancer, the answer will be Barrett's esophagus. It's talking about strongest risk factor. There will be thousands of smokers and maybe one or two will develop cancer. But if somebody has Barrett's esophagus, the chances of developing cancer is 40 times high. So if it is asking strongest risk factor for esophageal cancer, the answer will be Barrett's esophagus. Patient presents with jaundice. Ultrasound shows a shrunken gallbladder with dilatation of the intrahepatic duct. What is most likely diagnosis? Okay, so shrunken gallbladder and dilatation of intrahepatic ducts. Okay, so what would be the diagnosis? Okay, it's talking about the Claskin tumor. In the Claskin tumor, it's a cancer of, it's a type of cholangiocarcinoma, and it happens at the junction of the right and the left hepatic duct. And because it is above the gallbladder, so gallbladder is not distended. And the Claskin tumor is the most common site of cholangiocarcinoma. Patient with medial leg ulcer, what is the highest risk factor? The most common cause of medial side leg ulcer is the venous hypertension, the most common. So the answer will be venous hypertension. After resection of a polyp, the result was benign adenoma. Patient with no family history of what to advise? Adenoma, again depending on the size also, but we have to keep the patient in follow-up. And but adenoma is benign, so no problem, just lifestyle modification. Okay, but we have to keep the patient in. Colonoscopy has to be done repeatedly, not annual, but yes, we have to keep the patient in wait and watch. It depends on what is the size of the polyp. It is one or multiple. What is the size of the polyp? Whether less than 1 centimeter, more than 1 centimeter. Second, it also depends on number of polyp, whether it is a single or it is multiple. Somebody having more than multiple polyps with more than 1 centimeter size is more risk factor for cancer. Usually, an adenoma takes 10 years to develop into a cancer. Patient came 3 days after Roux-en-Y surgery, complaining of fever, chills, and left shoulder pain. So, is somebody having post surgery 3 days after, fever, chills, and left shoulder pain? So, there is a collection in the in the left subphrenic region. So, we have to go for CT with contrast. Diabetic patient. Okay, this is a repeated question. Repeat biopsy. Now, the patient is on NSAID. Patient is sudden severe continuous pain. He denied any history of vomiting, constipation. Okay, so we have to think about perforated peptic ulcer. Repeated question. Now, patient. Motor vehicle accident, complaints of shortness of breath. While examining the patient, there was a signs of respiratory distress and distended neck vein. Chest examination reveals hyperresonance. Okay, so the patient is having respiratory distress, distended neck vein, and the patient is having hyperresonance. So hyperresonance means the patient is having pneumothorax, and this may be a tension pneumothorax because the patient is having distended neck vein and respiratory distress. So needle decompression should be done, and immediately followed by chest tube insertion. Patient post hernia repair, when she can get pregnant? Not a very good question, but yes, at least we have to wait for 1 year at least. Patient developed circumferential right forearm burn. Any burn which is circumferential, it's bad because this may press the vasculatures, and this is what is happening here. So what you have to do is you have to do the ischiarotomy. You have to cut the ischia. What differentiates between chronic or acute ischemia limb? What In the chronic, we always we find the history of intermittent claudication. Okay. Case of pancreatic pseudocyst, one is 18 centimeter. How to manage it? Pancreatic pseudocyst we have managed in the earlier video. Internal drainage should be the best, and it should be done after 6 weeks at least, and it should be more than 6 centimeter. 17-year-old male on mechanical ventilation. Oh, come on, what is this? "17-year-old male on mechanical ventilation admitted to ICU due to intracranial hemorrhage. Days later, he developed ground coffee vomitus." Okay, so the patient is developing hematemesis, bleeding, and patient is having intracranial. Basically, the patients who are admitted in ICU, it's very common to find hematemesis, and this is basically because of the stress gastritis. It's basically because of the stress gastritis, and there is a typical name for this. Is known as Cushing's ulcer. It's known as the Cushing's ulcer in a case of trauma to the head, while it is known as Curding's ulcer in the case of burn. So basically, it is a stress gastritis. Lactating mother with a breast mass, thinning of the skin and tender. So lactating mother's breast abscess. If the skin is gone, you should go for. Ideal is you go for incision and drainage. Patient underwent sigmoidoscopy, found sigmoid lesion, histology sigmoid adenocarcinoma with free. Now, if the patient is having sigmoid adenocarcinoma, the first thing, as per the management, we have to, if the patient is not in acute obstruction, we have to first stage the disease by doing the CT scan. We have to do the full colonoscopy to rule out any other lesions. So, question is incomplete. We have to go for full colonoscopy first to rule out any other lesion. Then we have to stage the disease by doing a CT scan. But if the patient is in obstruction, we have to go for some emergency surgery. 45-year-old patient has a mass 5 centimeter in the right upper. Five centimeter breast mass. Okay, that is done. 45-year-old patient has a mass 5 centimeter right upper limb. Okay, so any mass in the right upper limb or lower limb, we have to rule out sarcoma. So we have to do a core needle biopsy. It is maybe a soft tissue, soft sarcoma. Adult, we avoid doing the incisional biopsy, okay, because making an incision, it may spread the cancer. Core needle biopsy is the best. Adult with hypertension, diabetes, has 2 months history of a small perianal painful swelling. His blood pressure is 160. So basically 2 months history. You are finding a long history, a small painful perianal. So it may be perianal abscess. So maybe the duration is giving wrong here. If it is asking about thrombosed pile is a condition where there is thrombosis of the pile, usually the external hemorrhoid, and it is said to be 5 days painful period. So patient has pain only for 5 days. So what is the management of thrombosed pile? Thrombosed pile says if the patient has come early within 2 days, then we should go for surgical excision of the pile, so it decreases the pain. But if the patient has already crossed 2 days, then we should just wait and watch, conservative management, because most of the patients will be normal after 5 days. 62-year-old male with BPH, his BMI is 41. What is the risk of BPH in this case? So rubbish question. BPH is associated with the age, so answer will be age. Patient of history with pancreatitis, now referred to surgery clinic for mild abdominal pain. What is the initial investigation is always ultrasound. Thyroidectomy patient, respiratory distress, expanding mass, so it is a hematoma. Remove the suture in the ward, evacuate the blood. Then you take the patient to OR to find from where the blood is coming. 6 hours, same repeated question. Patient with penetrating chest trauma, stable, he developed hypotension, 3D pulse, raised GVP, chest clear bilaterally. So chest is clear bilaterally, we rule out tension pneumothorax, so it is clear case of pericardial tamponade. ICU has source with exposed necrotic in subcutaneous tissue. So we are always debridement should be the first thing. Debridement and dressing should be the first thing. The vacuum is not always used as a first measure, so we should always go for debridement and dressing with secondary closure first. Patient thought to have appendicitis, did appendectomy. Pathology shows carcinoid tumor 1 centimeter. Carcinoid tumor 1 centimeter, we have to just follow the patient. We have to just wait and watch. Patient undergoes esophageal dilatation. Now with chest pain, subcutaneous crepitus. Okay, subcutaneous crepitus, chest pain, it means the patient is having esophageal perforation. The ideal management, the best management of esophageal perforation is surgery, which should be done within 24 hours. We have to do a proper drainage because there is a lot of fluid in the mediastinum, in the pleural, so we have to do a proper surgery within 24 hours. The results are good, and we have to drain the mediastinum region. Patient presented the neck swelling. She is completely asymptomatic. Neck ultrasound was done, revealed a solid mass of 7 mm with regular margins. Which of the following is the most appropriate? Asymptomatic. So neck swelling, she is completely asymptomatic. Neck reveal a solid mass. Okay, 7 mm mass is not a big mass, but okay, we have to, like, we should go for a FNAC to check for what is this mass. Case of abdominal aortic aneurysm, the patient is unstable. Present after, so any patient, tender pulsatile, any patient who is having abdominal aortic aneurysm and the patient is unstable, take the patient for laparotomy as soon as possible. Tender pulse. So it's, you don't waste time. You have to just take the patient for laparotomy fast. 47-year-old female presents with iron deficiency anemia, 3rd degree hemorrhoid. Which of the following is the most appropriate thing to do? We have to rule out any other cause of anemia in such patients, especially in the old patients. Hemorrhoid is there, but we have to rule out any bleeding source from the colon, any malignancies. So we should ideally do a colonoscopy. Patient underwent lab chole for multiple stones 7 days ago. Present with vague abdominal pain. On examination, on ultrasound, there is fluid around the gallbladder. So the patient is having collection of fluid around the gallbladder, and CBD is dilated. So what is the most likely diagnosis? So here, what most likely has happened is that the cystic duct stump is blown away, is opened up now. Cystic duct stump is open up, and all the bile is collecting in the gallbladder fossa. So what is the reason of cystic duct stump opening? The most common reason is here we are finding the CBD is 9 mm. So CBD is dilated. So most likely the patient is having a retained stone in the common bile duct. Old patient did total thyroidectomy. Then he developed swelling in the neck with inspiratory, again surgical evacuation. Patient did upper endoscopy, squamous cell carcinoma. Which is the following is risk factor for esophageal cancer? The most common risk factor for squamous cancer, specifically it is smoking and the alcohol. If it is an adenocarcinoma, it is the Barrett's esophagus. 25-year-old man, laparoscopic cholecystectomy with sudden abdominal pain, vomiting, mild general vital multiple air fluid level, so and dilated loop. So this having multiple air fluid level, so patient is having intestinal obstruction. We have to do a CT scan of the abdomen to look for the details of the obstruction. Patient with rectal bleeding, 5 and 7 o'clock, sclerotherapy done. What type of hemorrhoid treated? Okay, sclerotherapy is never done in the external hemorrhoid, is always done in the internal hemorrhoid. So sclerotherapy is usually done in the 1st degree and the 2nd degree hemorrhoids, bleeding hemorrhoids. Patient presented with dysphagia to liquids more. So dysphagia to liquids more goes in favor of ecclesia cardia or motor diseases of the esophagus. The first investigation to be done is barium swallow. After that, we have to do the other investigations. 24-year-old medical and surgically free presented the intestinal obstruction. Suspected to be having a small bowel obstruction. What is the most common cause? The most common cause of a small bowel obstruction overall is adhesion. But here the patient is having medically and surgically free. So there is no history of surgery. So there is no question of adhesion. Then the second most common cause of intestinal obstruction is hernia. So here the answer will be hernia. Young male complained to the Well Baby Clinic. Examination, his right testes was palpable in the inguinal canal, in small in size and easily moved to the scrotum. The left is normal. What is the cause? Okay, so this is talking about a retractile testis. So how to differentiate between a retractile testis and undescended testis? One important point is retractile testis is the moment you will touch the patient, or even if the patient just stroke the thighs, the testis will go up because of the intense reflex. But the scrotum will be well developed. So scrotum with skin rugitis will be developed on both the sides. While in a case of undescended testis, the scrotum is not developed on that side where the testis is absent. So this is one difference. Retractile testis is totally benign, nothing to be done in patients. What type of polyp is highest risk of cancer? Highest risk is villous adenoma. 90-year-old with multiple comorbidity, multiple cancers in stomach, lung, but original. Okay, so 90-year-old patient, always the management will be palliative. So comfort and care will be our goal. 12-year-old boy, it is again is a repeated question, supracondylar fracture with distal radial pulse absent. So if the patient is having evidence of neurovascular trauma, we should ideally explore. So we should surgically explore because so that we don't miss any brachial artery injury or nerve injury. So surgical exploration will be the answer. 65-year-old male comes with mild intermittent urinary flow reduction, rectal examination, prostate specific and is normal. Ultrasound, prostate is enlarged, median lobe. Okay, so prostate is enlarged. So what is the management of the prostatomegaly? Nowadays, it is first we have to manage by drugs. If the drug management fails, then we have to go for surgery like TURP. So drug management, it is mainly the alpha blockers like alfuzosin plus 5-alpha reductase inhibitors. So these two, usually most of the patients are better on this. 28-year-old female come to the clinic complaining of off and on painless rectus bleeding. She had anal swelling that reduces spontaneously. Anoscopy showed hemorrhoid. There are three hemorrhoids at 3, 7 and 11 o'clock with active bleeding. Okay. So the patient is having active bleeding. What we can do is hemoglobin. We can go for injection viscotherapy and rubber band ligation, but rubber band ligation is better. Old patient underwent rectal surgery, then developed DVT. What is the management? Nowadays, for the management of DVT is low molecular weight heparin followed by warfarin. 27-year-old obese women present with right iliac fossa pain, associated anorexia, nausea. On examination, there is a moderate right iliac fossa tenderness, leukocytosis. Okay, so leukocytosis is there. So this is most likely appendicitis. But in females, it is there can be so many other things, other differential diagnosis of right iliac fossa pain. So I would go for, to confirm the diagnosis, I would go for first CT scan. CT scan is quite specific and sensitive to make a diagnosis of appendicitis. In males, usually the diagnosis is straightforward, but in females, we have to rule out other diseases of the females. Elderly patient with a small lung nodule less than 8 mm. He is asymptomatic, non-smoker, no family history. What will the next step? Okay. Now, if we are finding the nodules, so 8 mm is the margin. If somebody is having a nodule which is less than 5 mm, no history of smoking, we can just leave the patient like this. No need to go for repeat. But if the patient is having 6 to 8 mm, the chances are a bit higher. But again, we can just keep the patient in follow up. More than 8 mm, we have to aggressively go for repeat CT scan within 3 to 6 months. Within 3 months. Old male admitted as a case of large intestinal obstruction. Rigid sigmoidoscopy showed a mass in the biopsy was taken, came as adenocarcinoma. What is the next step? Now it all depends on whether the patient is having acute intestinal obstruction or patient is not in intestinal obstruction. If the patient is not in acute intestinal obstruction, we have to further go by doing like full colonoscopy to rule out any other mass in the colon. Plus, you have to stage the disease like the CT scan, and then we can go for further surgery. 56-year-old woman present to the clinic with non-healing ulcer over a right malleolus. She is hypertensive, pulse is normal, and local examination show dark discoloration of the skin around the ulcer. So dark discoloration of the skin around the ulcer. This is very characteristic of venous ulcer. Venous ulcer, the most common site is the gaiter area, and between the ankle and the calf. In the gaiter area, on the medial malleolus is the most common site. Medial malleolus is the most common site of the venous ulcer, and we always find there will be hyperpigmentation and discoloration of the skin. 45-year-old patient came with history of reducible hernia in inguinal region. It pops out every 2 days with mild pain. On examination, the inguinal rectum. Okay. So the question, it seems the examiner wants to ask you, hernia till patient is asymptomatic. It is patient is not having any pain, so it is not complicated. But if the moment the patient develops pain, it means there are chances of complications, and we have to talk about go for definitive surgery. Hernia complications are the first complication is adhesions will develop, and the hernia will become irreducible in carcerated hernia. So hernia will not patient will not be able to reduce the hernia. This is the first step of the complication. We have to do the surgery. Second step comes any moment patient may go into intestinal obstruction. Then third step is strangulation, and then patient may develop perforation peritonitis. So any symptomatic hernia should be treated as soon as possible. Patient with chronic lower limb ischemia present with sudden leg pain. So any chronic leg ischemia, sudden leg pain, diminished popliteal distal pulses. Okay, so that is acute. It is an acute limb injury, acute limb ischemia. And acute limb ischemia, we have to always start with the heparin. Okay. Patient present to ER after RTA with shortness of breath, tracheal shift to the left side. The lungs are expanded and widened mediastinum. What is the diagnosis? Widened mediastinum. It is trachea shift. Maybe thoracic aorta rupture. Okay, I don't. Patient present to. Okay, I will read the question again and write in the comment box. Time is less. Patient with epilepsy, most common epilepsy. The most common shoulder dislocation is the posterior. Patient post RT with massive bleeding in the nose and massive bleeding in the mouth and nose and mouth. It's an indication of intubation. 14-year-old female with epigastric abdominal pain since a month was complaining that is affecting her life on examination. Multiple bruises in the abdomen. When asked if she has separated, she fell over a cycle. Okay, one very common mechanism of injury in children that gives rise to pancreatitis is cycle handle injury. The child is trying to ride a bicycle and the handle of the cycle hits her abdomen, and it is very commonly it is a cause of pancreatic injury. So we have to look for pancreatic injury. So we go for a CT scan of the abdomen. Patient had polyp excised. Report was cancerous cells with free tissue margin. Okay. 5-year-old boy with one testicle which is undescended. What is your management? Okay, so obviously we have to orchidopexy. The ideal age of the orchidopexy, ideal age is 6 months and never more than 1 year. So this is the best time, because once the 1 year has crossed, the changes in the scrotum has already occurred. Changes in testes has already occurred. But still, even before puberty, we should try to do the orchidopexy, because it is said that it decreases the chances of cancer and the other complications. So we should always try to do the orchidopexy. This is one. Second, ideally it should be done at the age of the 6 months, maximum up to the 1 year of age. And if not, even after the whenever we come to know, we should do the orchidopexy, because undescended testis is a risk factor for cancer. Breastfeeding mother found unilateral mass on the lower outer quadrant of the right breast. Breastfeeding, it was erythematous and hot and palpation. Okay, so the patient is having an abscess, so aspiration antibiotics is an option. Okay, second GCS question. Okay, this is, we have to remember this GCS. In the GCS, one important thing is, which is the most important, in the EMV, it is the M part which is the most important. If somebody asks you which is the most important part in the GCS score, it is the M part, motor response. RTA patient came with deformed leg swelling. There is pain and paresthesia and absent pulse. Most appropriate management is, this patient is asking about the compartment syndrome. So you do the four compartment fasciotomy. Child has scrotal pain and expression. The cord was edematous and inflamed with a red right hemicosis. What is the diagnosis? We have to, any child with having scrotal pain, we have to keep in mind it can be torsion, it can be epididymoorchitis. So how to differentiate? In epididymoorchitis, we will get a history of fever. We will get a history of red inflamed scrotum. While in a case of torsion, it will be sudden pain without a history of fever. And one sign will be in the torsion of testis, if you elevate the testis, the pain is increased. While in a case of epididymoorchitis, if you elevate the testis, the pain is decreased. This is known as Prehn sign. So this is an important sign to differentiate between torsion and epididymoorchitis. Other thing is, in torsion of the testis, the scrotal reflex becomes absent. Cremastic reflex is absent, while in a case of epididymoorchitis, it will be there. So this is an epididymoorchitis, and the cause is basically infection. Neck penetrating injury in zone 1 with emphysema. So neck penetrating injury, zone 1, if the patient is stable, we have to go for CT angiogram. And if the patient is unstable, we have to go for exploration. Child after RTA, weak peripheral pulse. Next step is, okay, it has not shown his mental status. If the patient is having GCS score less than 8, then obviously you have to go for intubation first, as per the ABC management. So even if the patient is having an RTA, if the patient is totally conscious, oriented, speaking, that means airway is normal, then we have to think about just shock, that is fluid loss. But if the patient's mental status is abnormal, we have to go for intubation. Patient diagnosed with ulcerative colitis, screening for cancer starts after 8 to 10 years. 35-year-old lady, nipple discharge, it was intraductal papilloma. Intraductal papilloma, we have to first rule out the cancer, because so first we have to rule out cancer by mammogram and the ultrasound. Second, what is the management is, we have to remove the duct which is having papilloma, that is microdocotomy surgery is done. Case of cholangitis, what is the best imaging? It can be MRCP, it can be ERCP. ERCP has its own complication like in the form of pancreatitis, bleeding, etc. 38-year-old complaints of constipation, painful with positive crack, okay, anal fissure. So the patient is having Graves' disease, 30-year-old patient, hyperthyroidism, antithyroid drugs, exophthalmos. So it is a Graves' disease. Toxic. What is the okay? Shows no, patient is having diagnosis is toxic nodular goiter. So toxic nodular goiter, you have to go for near total thyroidectomy. In the case of Graves' disease, the management nowadays is the treatment of choice for males is radioiodine therapy. For young females and for growing children, the radioiodine therapy is avoided. Otherwise, for Graves' disease, the treatment of choice is radioiodine therapy. Again, patient has unilateral twisting swelling, red scrotum, go for epididymosis. Obese patient, female patient, diabetic, still, but she felt her white. What is the most appropriate? So here you have to calculate BMI. BMI is calculated by kg upon per meter square. Toxic synovitis, this is a repeated question. Femoral hernia, we have to always repair, whether it is asymptomatic, symptomatic, we have to repair it. Patient with hip fracture underwent what anticoagulation to be given to the defective? Enoxaparin, that is low molecular weight heparin. Okay. Cushing syndrome, you have to manage the hydrocortisone at the time of the surgery. 56-year-old patient presents with left lower quadrant pain and change in the bowel motion. Fever, left lower, again this is so left fever, left lower quadrant tenderness, old patient, constipation. This goes in favor of diverticulitis. Patient with cholelithiasis and common diet measures 12 millimeter. So CBD it is dilated here. So dilated CBD with gallstones, we have to rule out CBD stone. So best is we have to go for an ERCP. If there is a stone, we can remove the stone. Patient extubated, thyroid surgery, shortness of breath and respiratory distress. Both the vocal cords are intermittent. So in the case of total thyroidectomy, there is a risk of bilateral recurrent laryngeal nerve injury. So in this cases, the cords, both the cords come in the semi-closed position. So we have to re-intubate the patient. Young patient was rescued from a building. When he arrived at the hospital, he was fine, apart from mild drowsiness, and had singed facial and nasal hair. So singed facial and the nasal hair, it means the patient is having smoke inhalation injury. So what we have to do is we have to do an elective intubation. Female patient, 11 into 12 breast mass, so a huge breast mass, no palpable lymph node. This goes in the favor of phyllodes tumor. So phyllodes tumor is what is the management? Phyllodes tumor is can be totally benign, it can be borderline, it can be frankly malignant. So if it is like totally benign, we can just go for wide local excision. If the patient is having borderline, okay, we have to keep a watch for sarcomatous, and if it is frankly malignant, we have to go for maybe going for total mastectomy followed by radiotherapy, because there is no lymph node involvement, so there is no need of axillary lymph node dissection. So we can go by here, we can go for simple mastectomy, and depending on the malignant potential, we can go for radiotherapy. So I'm sorry, for malignant phylloid, it's not always we have to give the radiotherapy, but depends on the final biopsy report. Patient presented to the ER with right thigh swelling and hotness. Past medical history revealed that the patient had atrial fibrillation. Okay, any atrial fibrillation is a risk factor for embolus going. So this patient ideally is we have to go for femoral embolectomy. Okay, this is a repeated question. Patient is having old patient. Patient is having CBD is dilated and large gallbladder. So large gallbladder, CBD dilated, obstructive jaundice patient. So as per Kurwitz's law, we have to think about pancreatic cancer. Patient underwent left lower parathyroidectomy for primary hyperparathyroidism. So primary hyperparathyroidism, there can be two causes. It can be adenoma and it can be diffuse hyperplasia. So now the patient has, even after the surgery, the patient has high parathyroid hormone and calcium. So most likely the patient, we have missed the adenoma. It's very common to miss the adenoma. Young patient did hemorrhoid operation. Currently complaining of severe anal pain, defecation, digital exam did not complete due to severe pain. It may be hemorrhoidectomy is a risk factor for anal stenosis. So it may be one of the complication, may be anal stenosis, but here is not given to choice. So we may go for a fissure, but it is most likely it is talking about the anal canal stenosis. For hepatic hemangioma, we're not supposed to do anything. But if there is no choice, avoid excessive sport. But hemangiomas usually don't rupture, you have to keep in mind. So no need to do anything as such. Trauma patient with a multiple injury to axilla and lateral chest wall fracture, fourth, fifth well examination. Suction sound. Okay, so this is talking about open pneumothorax. The patient is having loss of chest wall, so and there is a suction sound. So this is an open pneumothorax. So what has to be done in the open pneumothorax? We have to do 3-side dressing has to be done, and 4 side has to be kept open. So 3-sided dressing has to be done. This is one. Second, we have to take the patient to the OR and repair the thoracic wall, and then we have to put the chest tube. So 3-sided dressing should be done in open pneumothorax. Okay, so the question is incomplete, I think, because the choices are not given. Okay, yes, I do agree. ABI should be done. In any patient who is having like claudication, giving a history of claudication, okay, or where there is a risk of peripheral vascular disease, ABI should be done. That is ankle brachial index should be done, and normally it is 1. So normally it should be 1 to 1.2. If it is 0.5 to 0.9, usually we get a history of intermittent claudication, and if it is ankle brachial index is 0.1 to 0.4, it is considered critical limb ischemia, and the chances of leg loss are very high. A healthy patient done a routine checkup, image revealed a polyp in the gallbladder measuring 0.6 centimeter. Now this is a polyp having 0.6 centimeter. A polyp is in gallbladder polyp is risky if it is more than 1 centimeter in size, more than 10 mm. If it is single, if somebody is having multiple polyps or a single polyp less than 1 centimeter, it is usually benign. But here it is asking about, so we have to refer the patient for surgical consultation. Patient diagnosed with acute pancreatitis 3 weeks ago, now present to ER, complaint of mild abdominal pain and tenderness. Ultrasound shows cyst measure 4 centimeter. How you will manage acute? So now, this is incomplete question, but still the patient has acute pancreatitis 3 weeks ago, and so when is pseudopancreatic cyst managed? Pseudopancreatic cyst is not managed before 6 weeks. So 6 weeks has to. So the question is incomplete, but we have to, what we need to understand is, if there is a fluid collection which is less than 6 centimeter, 6 week and less than 6 centimeter, no need of doing management. Most of the time it will disappear by itself. Male patient came to ER with right femur shaft fracture, hemodynamically stable, no other injuries. What is your priority? Okay, I go for ABCDE, but the femur loses a lot of blood, so keep a watch on the blood loss. Female doing annual mammography screen, time is allowed BERED 0 and areas overlapping. BERED 0 means the test is incomplete and we should do other test or repeat the test. Breast mass, infiltration to skin, palpable imaging, what to do now? Condyle biopsy. Okay. Patient with thyroid mass in one lobe. So if there is a one lobe mass, we should go for a hemithyroidectomy. Three-year-old patient came due to 10 centimeter hard immobile mass on the lateral neck area. Aspiration removed lymphatic fluid. Now the question is a bit wrong here. This is most likely asking about cystic hygroma, but it is not hard. It is cystic fluid. It is cystic fluid mass. The answer is surgical intervention plus sclerotherapy. Wherever we can remove by surgery, we have to remove by surgery, and in those areas which we cannot remove by surgery, we have to go for sclerotherapy. Question is incomplete. 18-month-old child with a left undescended testis not palpable in the inguinal region. What is that? So most of the time what happens is undescended testis. Usually it is a very common condition occurring in up to 3% of the patients. But most of the time by the age of 3 to 4 months, the testis will come to its original position, will descend. So we have to wait for some time. And most of the time, if in undescended testis is palpable in the inguinal region. But if the testis is impalpable in the inguinal region, we have to do a diagnostic laparoscopy to find the testis. Where is the testis? 30-year-old male had an open hernia repair for a few, presenting with reducible inguinal hernia. Okay, recurrent hernia, go for laparoscopic surgery. Okay, zone 3 again endovascular. Crohn's disease, retrocecal collection, go for percutaneous drainage. Okay, patient had episode of calculus cholecystitis. Now in the hospital asking about what is Calculus cholecystitis ideally should undergo surgery within 72 hours. Otherwise, we have to go to a delayed cholecystitis. Left breast mass, BIRAT 5, we have to do a core biopsy. "48-year-old female with diffuse goiter, lab showed high T4, low TSH, ultrasound shows bilateral thyroid nodule." So if the patient is having hyperthyroidism, so we have to first, the patient is having bilateral thyroid nodules plus hyperthyroidism. First we have to know from where this, what is the hot spot. So we have to do a iodine thyroid scan. So to look for whether the nodule is having hypersecretion, is it a hot nodule, is it a cold nodule. So first we have to do the thyroid scan, and then we can go for FNAC if it is a cold nodule. 12-year-old girl, again abdominal pain with history of falling from the bike. Okay, one go for CT scan. Again, the surgery, laparoscopy, this appendicitis is a clinical diagnosis, but yes, whenever there is a choice for the best investigation, we should go for a CT scan. Thyroidectomy, recurrent laryngeal nerve. 35-year-old, her father has colon cancer. Okay, so now regarding this screening, the one thing we should know, whatever age the cancer has occurred, in the next generation the screening should start 10 years before that. So if somebody has like 40 years colon cancer at the age of 40, we should start screening at the age of 30 in the next generation. Smoking, okay. Strongest risk factor, if somebody asks and the answer is smoking and GERD, go for Barrett's esophagus, go for Barrett's esophagus. 8 millimeter papillary cancer, less than 1 centimeter papillary cancer is usually not an aggressive type thing. We can just keep the patient in follow up. So RTA, you have to do a CT scan. ERCP, and which organ injured, there are chances of duodenal perforation in ERCP. Okay, 32-year female with 4 centimeter fibroadenoma with hyperplasia and atypia. Okay. What is the most significant risk factor of the breast cancer? Presence of atypia. Whenever there is an atypia, there are chances of cancer, but fibroadenoma is a benign disease. Okay, it does not convert into a malignancy, but sometimes we find malignancy associated with fibroadenoma, which is very rare. Chronic liver disease, hematemesis. Okay, stabilize the patient, ABC. So this is all. I try to do it in short, but the most important thing is this is not even 1% of the questions. It is just some are very bad recall questions. Okay, and many subjects are totally uncovered. So don't rely on this. Please rely on the book. We have to read the book for the proper examination. Thank you very much.